Good morning. My name is Bonnie Kidd. I am going to go ahead and share my screen. I chose to do my formal paper on neonatal abstinence syndrome and opiate-dependent mothers. I work in a regional transfer center in a labor and delivery unit where we have a 75-bed neonatal intensive care unit. Over the last 6 years, I've noticed that there has been an increase in patients that are opiate addicted. And I started my paper off by looking at some of the historical studies. There were two performed in the 1970s. The first, reported in 1973, showed that there was a stillbirth just prior to delivery at 39 weeks. And it was a retrospective analysis that covered 10 years and mostly reported on meconium-stained fluid. There was another study that was done in 1975, and it was a serial sample of amniotic fluid which showed epinephrine and norepinephrine in high levels. And therefore, the report was that there was some fetal distress occurring with detoxification. There have since been 5 studies performed between 1990 and 2013. There was a pre-viable loss during that period where patients were detoxed. Other than that, there were no other adverse side effects of having detoxified a patient. So let's define the problem. The intrauterine effects of the opiates on the fetus include preterm delivery, intrauterine growth restriction, and meconium-stained amniotic fluid. The next, of course, is neonatal abstinence syndrome. Neonatal abstinence syndrome has the babies in a lot of distress. They have increased oral and nasal secretions. They have difficulty maintaining their own temperature. They are easy to be overstimulated. They display a high-pitched cry. They have difficulty feeding and therefore slow weight gain. And they also have seizure activity. This is an incredibly expensive problem because it takes an average of 23 days to detox these babies off of opiates. And this costs an average of $94,000. So if we've got an infant being born with neonatal abstinence syndrome every 25 minutes, this is as much as $1.5 billion annually in Medicare costs. So more recent studies than the last one that was reported in 2013 include no detrimental fetal effects when the mother is detoxed from opiates, a significant decrease in neonatal abstinence syndrome, and an overall fiscal savings in comparison to detoxifying the mother while the baby is still in utero. The 2017 American College of Obstetrics and Gynecology opinion on opiate dependency in pregnancy was for screening. So there are 3 types of screening that they suggest. The National Institute for Drug Abuse Quick Screen, which it asks about drug abuse and determines a risk level, and then they try to assist and arrange for treatment. The next one is the Kraft Substance Abuse for Adolescents and Young Adults screen. And I really like this screen myself. I think that it applies to all patients across the board. It's very open-ended questions, just, about risky behavior overall. And I really, really like this study. The third is the SBIRT, or the Screening Brief Intervention Referral and Treatment Tool. It's a little bit more vague about exactly how to ask the questions. That's why the Kraft is more of my favorite. So you do this screening and now you're on the slippery slope. So what intervention do you choose? And is the patient going to be compliant? And is the patient going to remain compliant throughout their pregnancy and afterward? So the other recommendation that comes from the American Academy of Obstetrics is to continue methadone maintenance. Also to use buprenorphine and naltrexone. Those are other opiate antagonists. So we're just not there yet. First, we start off with hospitalization of the patient. We get them detoxified from the opiates. And then we get them into an outpatient detoxification program. There are not very many of those for pregnant patients. And then we start to look at long-term behavioral health programs. So the study from Stewart, which was also retrospective, it basically said it took so much time and so much effort, and there were so many moving parts to try and keep these patients clean and compliant that he found that the pieces just aren't there. And so if we can get these patients hospitalized and detoxed close to delivery, then the incidence of NAS is smaller, but it's just not in place yet. And there's a lot of work to be done. But as the cost rises for these infants that are born addicted, the offset of the cost that it would be for us to get these patients in and get them detoxed would actually be better. It would be more cost effective for us to do this. So the conclusion of my formal paper is, although it's best to decrease neonatal abstinence syndrome by detoxifying the mother prior to birth, everything we need is not in place to make that happen currently. It needs a lot of work. Thank you for listening and have a good day.